I think we move now to the next speaker, which is Dr. Coghill. Dr. David Coghill is very keen in the psychopharmacology of many childhood disorders. He's particularly interested in the psychopharmacology of ADHD, and he's started a very active research program on this topic, also studying cognitive measures, medication effect on cognition, as well as of all the disorders. And he has also been very active in developing, with a whole team of colleagues across Europe, in developing the revision of the guidelines for use of long-acting pharmacotherapy of ADHD. And we are very pleased that he can give us an update of these European guidelines. David.
Thank you, Jan. Before I actually get to my slides, I was just put in mind when I was listening to Jan's presentation earlier and looking at the results of the survey and listening to Miriam and Andrea, of a piece of research, small piece of research that I presented at a symposium this morning, which came from the Netherlands and which looked in another survey of parents' experiences of the treatment of ADHD at the type of follow-up that parents of children with ADHD experience. Now, the Netherlands is the country where there's the highest sort of per head of population use of ADHD medication. So it's a country where we must assume that the physicians are comfortable and are used to making a diagnosis of ADHD and treating it. But what jumped out at me from this patient-parent survey was that of the almost 1,000 parents that were surveyed whose children were taking medication, 20% of them received no follow-up, and of the 80% that received follow-up, of the 80% that received follow-up, over a quarter of them did not see a specialist. So 40% almost of the children with ADHD on ADHD medications were not receiving follow-up from specialist practitioners. And of those who did get follow-up, only a quarter actually had their symptom severity evaluated as part of that follow-up. Now, I think thinking about that, it's really quite astounding to me that was at least the perception of the parents. But I think it can help us to understand why, even if we are prescribing medication, we may not be actually getting the best out of that medication. And it's with that in mind that I think it's important for us to think about the guidance that is available and the guidelines that are available. And for me, justifies another presentation of these European guidelines that we've recently upgraded. Sorry, my disclosures are here, both those with the pharmaceutical industry and research from national bodies. The first decision we have to make about medication is whether to start it or not. And actually some recent reanalyses of the MTA study by Paramela Santosh, put together with the other historical knowledge that we've had, have, I think, given quite a cohesive way in which to make this decision. And what we would now suggest, and what the European guidelines have suggested, is... Sorry, there appears to be a bit missing from that. Let's actually... okay. Let's just take it from that. If you have severe, pervasive and disabling ADHD, then the first-line treatment would be medication. Here we're talking about the child with hyperkinetic disorder, the child who's at the most severe end of that ADHD spectrum. However, for those who don't meet the criteria for hyperkinetic disorder, but do have a DSM-4 diagnosis of ADHD, where the difficulties are more at home, we would suggest some home-based CBT, by that we mean some parent support and parent training. For those whose problems are mainly at school, some liaison work with school and possibly some self-instruction work for the child, and Professor Cooper's going to talk more about what schools can do. That these non-pharmacological interventions would be the first stop for these less severely impaired children. However, even for this group, after a reasonable trial of non-pharmacological psychosocial treatment, and by a reasonable trial in practical terms, we've meant around 3 months of trying to get it right. 3 months of your best efforts. If the child still has persistent problems after treatment, then medication should be considered. Now, for some of you, that will be how you've been practicing. For others of you, it would mean don't be quite so quick with using medication. But for some of you, it would also mean that those children with less severe ADHD that you've previously withheld medication from, yes, try the psychosocial treatments, but if they don't work, consider medication for them. And always remember that ADHD treatment is not just about reducing ADHD symptoms, it's about treating the whole child, and in that respect treating the very common and almost ubiquitous in clinical practice comorbidities that we find. So that would be the decision about whether to start or not. Once you've made that decision, it's then important to think about what is the right treatment. And I break down the practical treatment issues into these 4 stages, each of which I think deserves at least equal attention to the one previous to it. So you've decided to start medication, you then need to choose the right first treatment for that child. You then need to initiate and titrate that medication to get the appropriate dose for that child. Once you've got a child stabilized on medication, you need to be thinking about how to monitor their progress. And then if anything is suboptimal in the treatment, you need to have strategies to make changes in treatment. And again, I think the guidelines and good clinical practice can help us in all of these aspects. When we think about what is the right first medication, one of the things we need to think about is how likely is a child to respond to treatments. This is actually a slide that I stole from Professor Butelaar, but I think is a very important slide. It tells us that 36% of people would have a preferential response to dexamphetamine, 26 to methylphenidate, and 38 to one or other. When you put this all together, what we're finding is actually that around 70% of patients respond to methylphenidate. This is amalgamating data from all of the studies. 70% respond to an amphetamine, but 95% respond to one or the other. That means it's a different 7 out of every 10, and that 19 out of 20 of your patients will respond to one stimulant or the other. When we think about the non-stimulant, we can actually look at the data that we have on response or non-response to either stimulant medication or atomoxetine. And it's quite a confusing table to work your way through, but again summarized, what it would say is about 60% of patients respond to atomoxetine, and only about 40% of those who do not respond to stimulants do respond to atomoxetine at our current level of understanding and knowledge. So from my perspective, that would suggest that the bulk of patients would respond to a stimulant. Actually, if you try a stimulant and the first stimulant fails, then if you're looking at the likelihood of who will respond, the second stimulant is likely to be the next choice. And for those who don't respond to either, then you still have a choice with atomoxetine. We looked at this in a little bit more detail in the European guidelines group when we wrote our addendum on long-acting preparations. And this is the development group, and I only present this data on their behalf. We selected a range of specific questions. First, we asked, should long-acting preparations be used at all? We'd already satisfied ourselves that the short-acting stimulant preparations were effective and should be used in the treatment of ADHD. But should any of the long-acting preparations be used? If so, which ones? And if we should use them, which ones should be used in which circumstances? And we thought of 4 basic circumstances. What about if you're starting treatment afresh? Should you ever use a long-acting preparation there? And if you should, which one? What about the patient who's responded to immediate release medication? Should you consider long-acting preparations in that situation? What about the patient who has failed to respond to an immediate release stimulant? And what about the patient who might have responded but couldn't tolerate because of adverse events an immediate release stimulant? So these were the specific questions we asked. And also, if the choice is made to start an extended release stimulant preparation, which one should be used in which situation? What we did to answer these questions was carried out a systematic review with both a quantitative review and a qualitative review of all of the data regarding the long-acting stimulant medications. Now, obviously, if you want to compare 2 medications, the best way to do that is via direct head-to-head trials. And unfortunately, with the long-acting medications, particularly comparing a stimulant with a non-stimulant, the only direct data we had was between methylphenidate extended release and atomoxetine in one study. That study suggested that in certain situations for the overall patients, that the extended release stimulant, which in this case was oros methylphenidate Concerta, was more effective and more powerful than the atomoxetine. There is a suggestion that for those who have are new to treatment, then the 2 treatments may be more equal. The problem with that conclusion was that the study was not powered to look at that subgroup analysis. So I think the conclusions we can draw are not particularly strong. So we're left with indirect ways of measuring, and we looked at the effect sizes. And the effect sizes gave us a clear message that immediate release methylphenidate is equivalent to extended release methylphenidate, and both are greater in effect size than atomoxetine. The second way we looked at it was with what's called numbers needed to treat. How many patients do you need to treat in order to make one patient better? And actually looked at in this way, the immediate release methylphenidate, the extended release methylphenidate, and the atomoxetine were all equivalent in numbers needed to treat. How can we reconcile these 2 measures that give us 2 slightly different results? Well, one possible explanation, and we can only hypothesize on this, is that the relatively larger efficacy or the power of the extended release stimulants is seen more on the more severely impaired patients, and that the extended release stimulants and atomoxetine are more equivalent on the less severely affected patients. And that would give you this pattern of results that we find. But it's only really a conjecture at the moment, or a hypothesis at the moment. We'd need more studies to be able to decide on that. But what's also important, the effect sizes we were talking about for the stimulants were around 1, and the effect size for atomoxetine around 0.6. How do those compare to other psychiatric treatments? Well, actually, they compare both of them, the 1 and the 0.6, very positively. The effect sizes for antidepressants, SSRIs, and tricyclics in the treatment of adult depression or OCD is only about 0.5, less than that of the atomoxetine, half of that of the stimulants. And the effect size for atypical antipsychotics in the treatment of schizophrenia in adults is only 0.25. So actually we're talking here about a group of very powerful medications, and that even the atomoxetine with the lower effect size is actually a powerful medication being compared to an extremely powerful medication. And we see similar reflection of the power with the numbers needed to treat. We were talking about 3 or 4 as the number needed to treat, and for number needed to treat, smaller is better. And that for the antidepressants was 9. That for the antipsychotics was 20. So we are talking about very effective medications here. And we summarized all of the data that we had on not just efficacy, but also the duration of treatment, on compliance, on the dosing flexibility, the abuse potential and costs in this table, which you'll find as part of the European guidelines. So you can see that the stimulants are the leaders as far as efficacy goes, but only marginally. As far as duration goes, the extended release preparations clearly have the pride of place there. For compliance, again, we don't have good hard data on this, but one suspects that the compliance with the extended release medications is better than that for the immediate release. For dosing flexibility, at the time we did this study, then actually the immediate release was much more flexible than the extended release. The release now across much of Europe of the 27 milligram Concerta tablet actually increases the flexibility of dosing there, as you'll see later in this presentation. For abuse potential, again, the extended release preparations, but particularly atomoxetine, score very positively compared to the immediate release preparations. And as far as costs go, this is really where the newer preparations do lose out. They're much more expensive. So the increase in benefit has to be balanced off against the increase in cost. And that was a question that we had to answer before we could make the answers to our questions. However, we did feel that on the basis of all of this evidence, and it was a unanimous feeling amongst the group, that the extended release methylphenidates and atomoxetine should be available and should be used in Europe. However, we felt that they shouldn't entirely replace the immediate release stimulants. So answering our specific questions, what about the choice of medication for treatment-naive patients? Well, for most of these patients, stimulants will be the medication to start with. But some may start on atomoxetine. And the examples of that would be where you require or particularly require an action throughout the whole day and night. And that might be particularly welcome by families who are struggling very early in the morning or late evenings after the stimulants have worn off. Also, we must remember that atomoxetine will help some children who are not helped by methylphenidate, and vice versa. But this wouldn't usually be the case for the treatment-naive patient, where you wouldn't know whether they were going to respond to one or the other. And as I showed at the beginning, the likelihood of response is greater with the stimulants than it is with atomoxetine. And also, the balance of side effects are somewhat different. But again, I would argue that you don't know what side effects might be present for a child before you start the medication. So in most cases, this wouldn't be something that would help you choose your first medication. And also, but not on the slide, there will be some families who are very much against the use of a stimulant medication. And for those families, they need to have the choice of a non-stimulant medication. But I think also the opportunity for the physician to talk them through the myths about medication and about stimulants that Jan put forward earlier. So once we've chosen the first treatment, we need to think about starting it. And how are we going to start it? Well, I think the MTA showed us that titrating onto medication is very important. And definitely from my own clinical practice, before we started to titrate properly and systematically on medication, it was quite possible to find a child who had been started on a relatively low dose, who had been followed up sporadically, and it wasn't until 1 or 2 years later that you actually realised that they were being undertreated. And I still see cases that are transferred to me from other services where titration isn't a routine part of the practice, who they tell me are not responding to treatment. Actually, they're not responding to treatment at a very low dose. It's not systematically been looked at what is the right dose. I'm only going to go through the titration onto methylphenidate because, as I've said, stimulants, and it would be the same for dexamphetamine, are likely to be the first treatment for almost all of the children that we see. What we do in our practice in Dundee is look for maximum benefit at minimum dose. So we try to get the greatest positive effects that we can with the least adverse effects at the lowest dose that's going to give us that. We do a 4-week titration with weekly dose increments. There's no way to tell what the best dose for a child is by their weight, their age, the severity of their ADHD symptoms. So we feel that unless you have to stop increasing the doses because of adverse effects, each child should have the opportunity to try on each of the 4 doses that we use of stimulant medication. We have baseline and weekly monitoring, which is actually for us conducted by our nursing staff. The baseline measurements are hugely important. How are you going to know if someone's responded if you haven't actually measured anything at baseline? And we no longer record side effects in our clinic, we record other symptoms. So we ask you at baseline, how are you sleeping? What is your appetite? Is he tearful very often? How communicative and sociable is he? Has he ever been spaced out or zombie-like? Does he get periods of depression? And we ask these as everyday symptoms rather than just as side effects in order that we can rate as we go along. We use standardized forms and assessments. We get information back both from school and from teachers. We use a standardized ADHD rating scale as a clinician-scored instrument in every patient at every time. We measure standardized outcome measures using the CGI and also the CGAS. They're very quick to do and they're free. And as I said, we monitor other symptoms rather than side effects. And at the end of the 4-week titration, the nurse and a doctor together will review. What was the best dose? What was the best dose with the greatest effect with the least in the way of side effects? Did it work? Didn't it work? If it didn't work, then we'll immediately titrate you on to the next medication. For us, this would often be dexamphetamine, as we have that available. But you can make those choices as you go along. So 4 weeks into treatment, we have a clear idea about the optimum dose, at least the optimum starting dose, and about the response to that dose. So thinking there about when we might use the extended release stimulants, I tend still to use the immediate release stimulants to titrate onto because we're more comfortable with them. The parents can miss the doses if they do have problems. They're not stuck with a child who has side effects across a whole day, and we have a bit more flexibility. But for many of those, immediately after their titration, we're identifying some issues with compliance. We're identifying some issues with stigmatization or with school. So for those, we will quite often switch them from immediate release to extended release. And of course, we would switch to an extended release methylphenidate in that case. If the child has the adverse effects on methylphenidate, then often our next step wouldn't be dexamphetamine, it would be atomoxetine. And if the child's failed to respond to methylphenidate, the next option would be for dexamphetamine or atomoxetine. And of course, the choice of which preparation we use will depend on what the profile of effects we need across the day. Good pharmacological treatment requires good monitoring. And again, we use the same standardized procedures to monitor every patient on every occasion. I'm not going to dwell on that because I've already talked about it with titration. If you're going to make the best use of these new extended-release methylphenidate preparations, then you need to know their pharmacokinetics and their pharmacodynamics. And you need to have a structured system for monitoring the effectiveness that I've just suggested to you. Why do you need to know the pharmacokinetics and pharmacodynamics? Well, because these medications have a different duration of action. Equisim XL and Mediconnect Retard, 8 hours. Concerta XL, 12 hours. But they also have different immediate release and extended release proportions. And these different proportions lead to a different profile of action across the day. And what we know is that the effectiveness of methylphenidate across the day very much mirrors the profile of its delivery and the amount of methylphenidate that you have in your body at that point in time. What we've done, and you won't be able to read this, is that we've taken something that Jim Swanson said, and I could just blow up the top of this, that's actually the important part of getting the medication right is to get it right in the morning, to get the first 4 hours right. So what we've done to help us with the at times inflexibility of these extended release doses, but also to deal with the fact that we can't actually just easily switch from an immediate release dose of 3 times a day to an extended release dose because the immediate release portions are different, is that we have a chart, we call this the Rubina chart, that we use in the clinic to help us match and tailor the immediate release portion to that child's needs. If you get the immediate release right, the drugs are designed for the rest of the day to follow that. And in order to help us see that, we also just developed this tool that I'll show you very quickly called the Dundee Difficult Times of Day Scale. And what this does is helps us to track the progress of a child across the day. So we look at the different times of day. You fill in the slices of the pie to tell us what time of day do these different activities happen. You then chart how difficult each of those times of day is. And for here we have a child who seems to be having problems a little bit in the getting to school, but a lot at lunchtime, and some when they're getting home from school. What we did is we talk to the parent and we make an assessment of why these are problems. And here we felt it was the immediate release medication wearing off. And what we did is we switched from the IR methylphenidate to the Concerta. And here is what we found. So I think the summary is that the extended release methylphenidate and atomoxetine should be used. The child who's responded to immediate release methylphenidate, there are still often reasons to move them to extended release. When you're using long-acting preparations, you should probably almost always start with extended release methylphenidate and proceed to atomoxetine if the former is unhelpful. For the child who has the adverse event on methylphenidate, atomoxetine would be the extended release drug one should try. And for the child who's failed to respond but hasn't had side effects, either dexamphetamine or atomoxetine. And as I said, the choice of which extended release preparation will very much depend on the profile of action across time. Thank you.